I'm wishing, having heard all these conversations, that I might have talked about something slightly different actually, but I'm only going to give you really a little insight into a slice of our program of work in Queensland. And I'm sure you'll have lots of questions, and I'm very happy to talk to you afterwards about that. Really what I wanted to talk to you about was a business model which we've applied in Queensland called an MSP, or a Multisided Platform. And in the business world, this has been taken up quite actively by companies that you may know, little companies called Facebook, Uber, Airbnb, and they do this incredibly successfully. The whole point for them is to facilitate interactions between their customers, their clients, and the businesses. Now, if we take this business model and apply it in a health application, particularly in an oncology context, we might see how we can come up with a similar kind of concept. We're not claiming we're an Uber or a Facebook, but if you take, for example, eBay, another one of these MSPs, you don't have to know anything about who the business is that you're searching for when you go on there to buy your new heater for winter. You log on and you search for a heater, and up pops the first 50 or whatever businesses who are willing to sell something to you. So this is an approach that we've tried to use in Queensland, really, to connect people, to facilitate that interaction between our clients, our clinicians, and our data custodians, to bring them together in an application so that they can better access each other to improve services for cancer. We operate as a gazetted quality assurance committee. This is quite unusual in Australia. We have specific legislation in Queensland that allows us to access identifiable information without patients' express consent, on the condition that we use it for improving cancer services. So with that proviso comes great responsibility in terms of how we look after that information, what purpose we use it for, and how we share it. The whole aim of the program of work is clinician-led service improvement. We take that incredibly seriously. So the whole program of work is built from the grassroots up. It's not about the Department of Health or some other group coming in over the top and issuing edicts about how the program should function or roll out. We're currently chaired by Professor David Thiel. Many of you will know him. Just on that clinician-led service improvement, we have a whole range of subcommittees. I've just popped that up there so that you can sort of see the types of things we're talking about. So these are key clinicians in the state who are enthusiasts, who are leaders in their specific cancer fields, and we engage with them daily, weekly, monthly around activities that are important to them, around clinical issues that are important to them, about gut feeling that's important to them, things that they think might be awry in the system that they think they need some attention or some focus. So how do we go about creating this, what I'm calling a multi-sided platform, to facilitate this interaction between everybody? Well, we use multiple approaches. There's not one single solution that's going to suit everybody. So where possible, we utilise existing sources of data, and I'll talk about that a bit more in a minute. We haven't tried to, and we heard this earlier today, break down the silos. Silos can be quite useful. You know, those systems are often there for very good reasons. They serve a function. They might help you run your LINAC. They might help you do your billing in your clinic, or what have you. We're not trying to break down those silos, but we are trying to build bridges between them, or extract information out of them that we can turn into something that's much more useful for and value add for everybody. We also set about building a web application to fill the gaps, because there was some information that just wasn't captured anywhere else in any other system. And the other really important step was to combine all of this with multidisciplinary care. So our MDTs are really important in the state. It's through them that we're able to enact this whole program of work. We had a little bucket of money so that we could engage MDT coordinators across the state as well, so that they have some administrative support to keep those MDTs running and functioning. And the whole intent is to deliver this really highly clinically relevant information back to clinicians in a variety of ways, with a variety of systems and tools, so they've got meaningful data in their hands to help them make decisions around their MDTs and managing their patients on a day-to-day basis, but also to focus on those gaps in services and to look for where improvements can be made to improve it for everybody across the state. So where does our data come from? Who are our data custodians and partners in this space? There's a whole range of them. We currently have about 60-odd people who, or systems, I guess, that provide information to us that represent a whole range of clinical information across the state. So lots of good demographic data, lots of diagnostic information, things like the cancer registry, all the big treatment systems, the mosaics, the charms, the arias, etc., across the public and the private sector. Every single pathology laboratory in the state, both public and private, all feed their information into the great big pot. And what do we try and do with that data? Well, we're really trying to track that patient journey from as soon as we can find out about it right through to outcome, whether that be follow-up, survivorship, death, or whatever that outcome is for that person. The red dots are just to highlight, and again other people have mentioned this today, the gaps in relation to primary care in particular. So the Medicare data, the PBS data, which we would like to be able to access routinely to better understand what happens in primary care outside the four walls of a hospital. It's not a nut we've cracked yet, but we're still trying. So how do we actually do this? How do we pull all this data together in our multi-sided platform? All of our source data comes to us in that red layer at the bottom, and it comes to us in a variety of ways. Again, we're not too concerned about that concept of interoperability, which we've heard about. I have trouble even saying the word. If that data's being built or a system's being built for a specific purpose, then leave it there. We'll work out ways to connect that information with other information to make better sense of it. So it comes to us in real-time trickle feeds, right through to data dumps. I think we still get some of it on CDs or USBs from some hospitals because that's just the way they operate. We then run it through a quite sophisticated matching and linking process. We call it the wheel in-house, and we spin that wheel every week to update those 8 million people with their latest clinical information. So the repository actually holds information on every person in Queensland, whether you have cancer or not. And the reason that we do that is because we don't know tomorrow that you're going to come in and visit me, Phil, because you've got cancer. So we want that data to be ready and available for that clinician the minute that that person walks through the door, so that when they log into QOOL and look them up, the information is there. Out of that, there's about 550,000 people who have had cancer, going back to the beginnings of our cancer registry. The registry is really important to us. It acts a bit like a spine in the same way that Sue was explaining earlier. And we add an awful lot of information to that spine. All the information that's housed in our repository then gets pushed out into these applications. So QOOL is one of them, Oasis is another that sits on the side, and that's part of our feedback loop. So we've got a way to actually deliver that information in meaningful ways back to clinicians, and I'll show you some little examples of that. We also do a whole range of reporting on the information as well, and we'll look at some examples of that. So if we line all that information up now, we get a pretty good and comprehensive picture of that patient journey from the earliest moment we can find out about that person right through to outcome, as we said. What is QOOL itself? Well, it's a web-based application. You can access it anywhere, anytime, 24/7, anywhere in the world. It has a whole lot of security built into it, of course, so as an authorised user you can access it. It is system agnostic. It doesn't care where that data comes from. We draw it together from any source that we can lay our hands on. We try and provide it in as real time as possible. Now that is dependent on source systems, of course, and how frequently they can provide that information to us. But the whole intention there is that we're not duplicating then. We don't want clinicians to have to trawl through 15 different things to find the one single piece of information that could have been brought together with some smarts in the background. And the key focus, of course, is to support those multidisciplinary teams as they manage their patients. I've just popped in a couple of screenshots as an examples, but this one's looking at pathology in particular, both from public and private laboratories, so that when you're in that system, you don't have to go in and out of all of the path systems to find your information about that patient. So histology, bloods, tumour markers, etc., all flow in. The MDT is crucial, as I said, so all the diagnosis, staging and decision making is captured in the application. Where possible, we try and limit that free text because, again, it's difficult to analyse. We too do some work around natural language processing, which has been particularly useful for us in relation to cancer notification itself. We've actually just rebuilt the Queensland Cancer Registry in Queensland. It went live at the end of May. and we certainly use natural language processing for that, so we can make better sense of information that's captured within those pathology records in particular. Treatment information is integrated from all of those source systems that we talked about earlier. So in our application, anything that's purple means that you haven't had to collect that. So that's coming to you from Mosaic or from Charm or from a path lab, wherever we can lay our hands on that information. It's summarised for clinicians, so again, they don't have to make sense of it. What you see on the front end of Mosaic is usually not what it looks like in the back end. So there's an awful lot of business logic built into QOOL to make sense of that information, aggregate it, bring it together so that we can actually tell you that that patient's had 20 fractions and X amounts of greys and what have you, because it's not how it's stored behind the scenes. It gets used in a variety of ways. So here we're just looking at two of the reports that come out of the system. One is a summary report on just counting your numbers, how many patients go through your MDT each week, each month, each quarter, and what's happening with those patients. We'll look at that in a minute. It also has a big focus on care coordination, and care coordinators use this in particular to monitor their patients, what's happening with them, their episodes of care, what type of advice are they having to provide to those patients. They capture an awful lot of sort of patient-reported information in QOOL as well, around things like the distress thermometer or geriatric assessment tools, etc., are all built into that system so that they can track and monitor that as they go. Oasis, which I mentioned before, is the system that sits alongside it with containing all the analytics. It's web-based. It's like a halfway house between a full-blown stats package and your Excel spreadsheet. It's available to every hospital, health service, clinician, facility across the state, and it allows you to compare a whole range of clinical variables compared to your particular patient cohort or your hospital's cohort with the rest of the state, so you know that where you sit in that big picture. It's an easy web-based system that's got drag and drop functionality that anybody can learn to use in 5 minutes. Oh, and the MDT data gets updated every night. So if you've had your MDT today and you've captured information about your patients, that information is there and ready for you to look at tomorrow morning. So this is the sort of thing, someone was talking, I think Elizabeth, you were talking about dashboards earlier, that we have built into the system. So if I look at my MDT, this might be the type of information that I want to look at, and I've just popped a little trend in there for the last, I don't know when until, 2015. Looking at the number of patients that we had reviewed. I think this is a brain cancer meeting. And we calculate things for that group already, so they can look at things like their survival, how many of my patients were Indigenous, did they come from rural or remote areas, so on and so forth. Incidence mortality, all that sort of epidemiological information is contained in there, survivals. And this one again, we're looking at brain cancer and childhood cancers compared to AYA group compared to adults. And that's calculated for the clinicians already, so again, they don't have to know how to run that stats package. All they have to do is press the button. The other big use of this information, of course, is the more statewide reporting. So as a state, we now have a way to monitor what's happening in cancer services in Queensland. And we've just started to produce the annual index. We're just about to publish this again next month. And it contains a whole range of indicators across Queensland, for the last 10 incident years. This next version will be expanded to include some additional cancers. We'll also have radiation therapy and chemotherapy utilisation rates for the first time in Queensland at a statewide level, with some information about timing to those treatments. So how long has it taken a patient to get from diagnosis to first treatment for each of those treatments. I'll skip through those. We spend a lot of time, of course, reporting and feeding back to hospitals. That's the purpose, that's why we exist. We've generated over 1,500 reports in the last 5 years for clinical teams. Many of them are very hospital specific, they're not publicly available, but all of the publicly available reports are available on our website. And you're very welcome to go and have a look at those. There's some good information in there, and we're also very receptive to feedback. We want to know what impact these reports are having and whether the information is tailored enough or meaningful enough for people to make sense of it. So if you have any questions, please conscious of time, do come and have a chat to me. The good news is this is actually making a difference in Queensland. We're seeing practice change. Hospitals are changing the way they manage and deliver cancer services across the state, and that's great because that's why we exist. Thank you.